CS has given a specific date. This is the sort of responses we expect in this House. So I will wait for the 8th of May and expect that communication from him. I also note, Honorable Speaker, that he has included the claim on Master Robin Murimi Majao. Mr. Speaker, you remember this is the last time the CS was here was over 6 months ago, and I personally handed him the documents he said he had not received. I am happy that he has acknowledged. But Speaker, my only concern is with regards to part C of that question. When he uses language that is vague, I wish he was as specific as he has been in part B and A on when these remaining claims will be settled. Even a timetable will be acceptable at this particular point in time, so that we can be able to answer the questions of the people, that at least there is a timetable encompassing a period of 3 months, 6 months, not just saying that they will be systematically settled against a broader NHIF legacy dates. I thank you, Honorable Speaker.
Honorable CS.
Honorable Speaker, Honorable Senators, the last 2 bits are part of, including even the 116, are part of the bigger and wider NHIF legacy debts. And we have separated into 2 categories, 0 to 10 million, accounting for about 5.3 billion. What we have verified as genuine claims was 4 billion by the time the supplementary estimates were being tabled in the House. I'm happy to report that the National Treasury has factored in the 4 billion. So we will start paying that from next week. The other amount which is being verified now, I want to assure the House, because we work through a budget circle, the National Treasury, we will factor in the next budget, 26-27. And once the House passes in the month of June, July and August, we will pay the 2 other, all outstanding, including the inpatients, the outpatients, and there are many, many other claims, surgery, maternity, the many, many other claims upon verification. So, Honorable Senator, the one for the 8th, please hold me to that. These other balance, hold me to that. By August, there will be no outstanding verified claims of the former NHIF.
Now we have 3 minutes left to this question. Senator Manzo.
Not on this one.
Senator Matinga.
Thank you very much, Mr. Speaker. Let me start by thanking the CS for the answers that he's given, noting that the SHA still has a lot of issues, especially in pending bills non-paid and not honored. Does the CS plan to conduct civic education on how people should go forward in making their claims in SHA, so that they can be able to differentiate when their claims are valid, what they need to do? Because we notice that this is one of the biggest challenges we have on the ground, that people are saying SHA is not working, but mostly because of misinformation. Does the ministry have, or has the ministry budgeted, as in this strategy, a civic education to be conducted so that people understand how to fill in the claim and how and when to claim what amount? Thank you very much, Mr. Speaker.
Senator Newton.
Thank you, Mr. Speaker. My question relates to Edu-Afya medical scheme. So could the CS maybe bring us to speed on how pupils and students are now covered after the medical scheme under Edu-Afya medical scheme was done away with, and what benefits, if at all, are the learners entitled to under any such new arrangement? Thank you, Mr. Speaker.
Senator Mungatana.
Thank you, Mr. Speaker.
mean, he's our neighbor from Garissa in Tana River, and he has made us proud. But there is one question I want him to clarify, to take this opportunity to clarify. There were many issues about false claims, things that were bordering on criminal conduct by hospitals and doctors and what, and we raised a lot of hell together with the public. I just want him to tell us how many people have been taken to court, how many have been charged, and what is the status. He can use this opportunity to tell us where we are in terms of recovery for some of those crooks who had infiltrated the systems in SHA. I thank you, Mr. Speaker.
Honorable CS, you may now proceed to respond.
Honorable Speaker and honorable members, let me start with the honorable senator from Nyeri, that yes, we're doing a lot of civic education, and civic education is the linking, the missing link in the whole of SHA. But honorable Speaker, if you go to a hospital, and I'm sure that senators will agree with me, I was in Bungoma, and I went to the maternity wing. And out of 40 women who were in the queue, only one lady was not registered with SHA. And when we asked her, she said she doesn't have the phone. The only phone they use is the one that belongs to the husband. So Kenyans have registered. As of last night, 30.6 million Kenyans have registered with the Social Health Authority. It's working. This week, from last Friday to going on up to this Friday, we are paying 13.5 billion shillings to all health facilities, from primary health care levels to our referral hospital. And I can even provide the list totaling to 13 billion. That is the kind of transformation we are talking about. Nyeri County, I really want to thank, is among the counties which is, I think, number 3 in terms of registration. And when I look at even the list, Madari, Nyeri, both the faith-based, the county, and even the private are receiving money. So civic education, we need to do more, but I really want to urge Kenyans who are registered with SHA to download an app called Afya Yangu. Afya Yangu, Speaker, if you download it, it gives you all the information from your nearest hospital, the doctors you require, the amount of money that each benefits or tariffs, and it tells you this is the amount. And if you walk around, even I met a policeman as I was coming to Senate, and he told me I can see my balance on my phone if you download that. So we'll do more civic education. I think our team were in Nyanza. They have finished Nyanza region. Today, the whole team of SHA are in the coast region, and then they will go to Rift Valley, and we are meeting all the players. To Honorable Nyutu, Senator Nyutu of Muranga, yes, Idu Afya First was funded by government, and it has left us with a huge debt because government did not pay during the transition. And that is why the question that the Honorable Senator for Nairobi is asking. But that has been transformed. All our children are covered by and they are dependents of their parents. So once you register with SHA and you pay for SHA, particularly first at the primary health care, it's free. You walk in, you walk out. Anybody who walks to a dispensary and health center, Parliament has appropriated the required money. So our children, their parents can walk to any of their health center for outpatient services, free, paid by government. When they come to specialized treatment, the parents covers all their children up to the age of 25. So it's even more better improved cover than the Edu Afya. Honorable Mungatana, yes, the biggest challenge in any health insurance globally, even in the US, is fraud. In fact, in the US it's 28%. The country with the lowest is Estonia, with the 6%. But since April last year, when I went to that ministry, it was at 26%. Now I want to confirm to the country, because of the actions we have taken, we are now at below 6%. What have we done? We have closed over 1,200 facilities. The DPP has received over 24 files, of which I think 18 of them, including 2 former CEOs of SHA and NHIF, have been taken to court, and many staff of NHIF, SHA, and even the regulatory bodies like KMPDC who register. As we sit here, the DCI has close to 81 files, of which last week he has submitted 24 more files to the DPP. We will not relent on fraud. We closed, and the senator for Bungoma will agree with me, we closed Bungoma West Hospital. We closed 13. Calvary Hospital in Bungoma, we closed. And let me say it for the avoidance of doubt, so the senators from those areas can listen to me. We have flagged out 5 counties as the epicenter of fraud. And those counties are Mandera, Kisii, Migori, Homa Bay, and Wajir. And we will not relent on it. And we will not relent on it. And I'm talking of not the county alone. I'm talking of all the facilities. Majority of the fraud is taking place in the private health facilities. But what are we doing? As the senator for Nyeri have asked, we have started to reduce fraud and to reduce rejection. We have rejected claims worth, as of today, 13.2 billion. If we did not reject those claims, in the former NHIF, they could have paid. And we'll keep on rejecting, and it will increase. Because a good example, and I said on the floor of this house, and the good ladies will agree with me, if you claim for a maternity, and your claim form, one document called birth notification is missing, that claim is rejected. The only thing that can tell us a child has been born is if you produce a legal document called birth notification. So we're fighting fraud, and I really want the leadership here to help me fight fraud. When I close a hospital, please don't call me. I have seen many people calling me, but I have refused to call. I have refused to budge. On fraud, I will not. And because you cannot steal patients' money meant for the Kenyan patients. If you want to steal, go steal the money meant for roads and water. But somebody who is on a hospital bed, I'm not saying you should even steal for roads, but the more serious, if somebody on a hospital bed, if you steal his money, and that's why even now there's a lot of noise, because I am protecting teachers' money. Because some facilities are used to stealing from teachers. And I'm meeting the teacher union leaders. I'm telling them the only thing I'm doing, I'm protecting your benefits. Thank you, Mr. Speaker.
We'll now proceed to question number 014 by the Senator for Makueni County, the Honorable Daniel Maanzo.
Thank you, Mr. Speaker. Question number 014. A, could the Cabinet Secretary provide a breakdown of the management and utilization of the Tobacco Control Fund, specifically outlining how funds have been received and allocated as stipulated by Section 7 of the Tobacco Control Act of 2007. B, what measures are in place to ensure transparency and accountability in administration of Tobacco Control Fund? And C, how is the ministry addressing the current influx of oral nicotine pouches, e-cigarettes, and such other tobacco products, almost products amongst the youth and children? D, what steps has the ministry taken to ensure compliance of the tobacco control regulations, particularly regarding the solatium contribution from tobacco manufacturers and importers, following the judgment of the High Court in Constitutional Petition number 143 of 2025? And E, how is tobacco control being coordinated within the ministry and across the county institutions, particularly in the context of devolution? I thank you, Mr. Speaker.
Honorable CS, you may now respond.
Honorable Speaker and Honorable Senators, let me just make a confession that since I became the Minister for Health, one of the hardest things I'm yet to crack to the end is this tobacco business. And I really want to thank Senator Muma, because she has brought a bill to this House. I really want to thank her. It's going to address a lot of the issues that I met, and now it's in the National Assembly. I pray that they will not amend the provisions the Senate has passed, because the cartels in this industry will do whatever it takes that what the Senate has passed is undone. But coming to the question, the Tobacco Fund is established under Section 7 of the Tobacco Control Act of CAP 242, and it's financed through various sources, and I think I don't want to go into the sources. The member, Honorable Manzo, has it. Maybe just to add that the solatium compensatory contribution payable by licensed cigarette manufacturers or importers in the country may be determined by the board. That's one of the biggest fund. Honorable Speaker and Senators, the primary operational source of the revenue remains the solatium compensatory contribution, which supports the implementation of tobacco control programs countrywide. I have given the breakdown of the financial performance of the fund since 2022-2023 financial year up to 2025-2026 financial year. I have given the breakdown. In 2023-2024, the allocation that was received was 756 million. In 2024-2025, 831 million. And in 2025-2026, 872,550 million. Then on the other side is where we have the expenditure amount utilized. The utilization part of it, I have enumerated year by year. Part of it is public awareness, communication campaigns, the national tobacco cessation programs, where we do screening, we do brief interventions, we do referral of patients for treatment, what we call SBRT initiatives. We do review of the tobacco regulatory framework in accordance with the global standard. And we do develop and review graphic warnings on tobacco products. And of course, training of the enforcement officers, stakeholder coordination, a number of functions. So the interventions really is geared to strengthen, enforce, and do public education efforts. How we have utilized these funds, Honorable Speaker, the implementation of the activities for this financial year is ongoing. There are many activities. There is the county level advocacy and awareness. We are doing construction of cessation and rehabilitation centers in Meru and Nakuru, research on emerging tobacco and nicotine products, drug demand reduction campaign, mainly in the coastal areas, targeting our youth. Honorable Speaker, the Tobacco Control Fund remains a very key instrument in financing Kenya's tobacco control agenda. If it's managed with a clear legal framework that ensures transparency, accountability, and target allocation of public health. Honorable Speaker, I think in a week's time I will table a report of auditor's report done by the National Treasury on how this fund has been used. I think they have just completed this week, and they will brief me, because I had to find out what is going on and how a proper audit should be done before an audit of this house is done. So the ministry were very much committed to improving the efficiency, the strengthening of the procurement system, how prudent use of resources, and all this must be in line with the statutory requirements. What measures are we putting in place to ensure there's transparency and accountability in the administration of the Tobacco Control Fund? Honorable Speaker, we have initiated a number of key measures. One of them is the legal and statutory framework. Because the fund is established under Section 7 of the Act with clear defined revenue resource and restricted expenditure purpose, we will ensure that funds are used strictly for tobacco control program. 2, we have designated under Section 8 of the fund to be managed by a different designated accounting officer who will be responsible for the financial control, for compliance, and for proper record keeping. Of course, thirdly, we have the public finance compliance. The fund operates within the framework of the PFM Act. So every officer, every PFM officer must adhere to budgeting, reporting, and expenditure controls. And annual audits are undertaken by the Office of the Auditor General, providing independent verification and financial statements and compliance. And as I said, we have just completed an audit by the auditors from the National Treasury on this fund, so that we just get a feel of what is happening, and we will share with the House. Conflict of interest safeguards. The Act prohibits acceptance of funds that may create conflict of interest, particularly from tobacco industry related entities. And then we have the parliamentary oversight. Exactly what I am doing this afternoon, and I'm sure in our committees, the fund remains subject to parliamentary scrutiny through audit reports and accountability process. Finally, the tobacco control regulations and related policies provide operational guidelines, monitoring, and performance evaluation mechanism. Honorable Speaker, these measures collectively will ensure that we put in place a very strong system of transparency and accountability in the management of the Tobacco Control Fund. And as a ministry, we remain committed to strengthening the implementation and ensuring prudent, efficient, and lawful utilization of all resources in support of public objective. Honorable Speaker, on the question is what is the ministry, or how is the ministry addressing the current influx of oral nicotine pouches, e-cigarettes, and such tobacco products among the youth? Honorable Speaker, we must recognize that the evolving nature of tobacco and nicotine products and associated public health risk, particularly in increasing appeal to the young people. So we are controlling how the package, the graphics should look like. So we are implementing a multi-sectoral approach comprising of legislative, regulatory, enforcement, research, public health intervention, which I have outlined in my answer. What each area, whether it is legislative, how do we strengthen, and that's why I talked about the bill before, the Tobacco Control Amendment Senate bill, was meant to strengthen legal framework under the Tobacco Act. And it seeks to particularly explicitly regulates the electronic nicotine delivery system, including the e-cigarette and the oral nicotine. And this is where, Honorable Speaker, you might find your daughter in the house. You think she is using a lipstick, but that is a drug. Something that is being laced with tobacco. So they are using all types of different methods to attract our young people. So that law of the Senator Muma has really dealt with all the legislative loopholes. Then we have the how do we protect our minors and restriction of access. We want to make sure that the sale and the distribution of tobacco and nicotine products to minors, including limiting license of retail outlets near education institutions. Then we have the product regulation and pre-licensing control, where we make sure that we do a lot of due diligence before we give an importer or a manufacturer the license. Of course, we have enforcement under the existing legal framework. We do market compliance and licensing control, and above all, we do verification and compliance outcomes. The question D was what steps has the ministry taken to ensure compliance with tobacco control regulations, particularly regarding the solutium contribution from tobacco manufacturers. Honorable Speaker, the ministry remains committed to the rule of law while safeguarding sustainable financing. And in this regard, we have taken the following measures: compliance with the court decision, which the Honorable Member has said. We are implementing the High Court judgment in Constitutional Petition number 143 of 2025 in all the regulatory and administrative actions. 2, we are strengthening our enforcement to ensure that all manufacturers and importers comply with the statutory obligations, including the payment of the solutium contribution. Licensing control, payment of all statutory contribution we must make sure that they are accounted for, and issuance and renewal of license. Then, of course, we do interagency coordination. Honorable Speaker, we do monitoring and evaluation, verification of all the systems, tracking payments, verifying compliance, in collaboration with oversight institutions. How is tobacco control being coordinated with the ministry and across other government institutions, especially in the context of devolution? Honorable Speaker and members, tobacco control in Kenya is implemented through a coordinated multi-sectoral framework under the Tobacco Control Act. And this is in line with the constitutional provision on devolution. So coordination is undertaken as follows. The national government, which is the Ministry of Health, provides the overall policy direction. It provides technical leadership and coordination of tobacco control programs. Then we have the interagency collaboration. The ministry works with relevant government institutions, including the ministries responsible for finance, interior, education, trade, to support the enforcement, the regulation, the taxation, and the public awareness. Then we have the Tobacco Control Board. The Control Board provides the intersectoral coordination and advisory support to ensure harmonized implementation. Then we have our county government role, which is for the implementation of the tobacco control activities, including enforcement of smoke-free laws, health promotion, and cessation services, which we work closely, very well, with the county governments. And of course, we do monitoring and evaluation. Honorable Speaker and members, tobacco control is effectively coordinated through a structured national and county framework to ensure policy coherence, efficient implementation under the devolved system of government. Thank you, Mr. Speaker.
Senator Manzo, any supplementary question?
Yes. Mr. Speaker, I would like to ask the Cabinet Secretary, now that this House, the Senate, gave him very good regulations and the graphics last year to control tobacco use, one, how is he also reaching out to Kenyans consuming raw tobacco by their mouth, unprocessed, which could even be more dangerous than the e-cigarettes and what people are circling like sweets. Finally, we've not seen those regulations in the billboards as we had given him. It's almost a year now. And how is he going to make sure that the accounting happens? He said in a week's time or 2 weeks. Could we kind of then maybe give him another date so that he can present the Auditor General's report on this and how the money, 700 million or so, has been used in this regard? I thank you, Mr. Speaker.
Honorable CS, proceed.
Honorable Speaker, I think the Honorable Senator for Makueni is in a better position to get the Auditor General's report. All that we get ourselves is a management letter We provide all information. The Auditor General reports, is an independent office. It reports to the houses, to Parliament. So I think the Honorable Manzo, you can check through the Auditor General reports. But I agree with you. We must make sure every coin from the Celestial Fund is accounted for. I agree with you, and we had a session, and we have now enough money. Since I went there, I have stopped a lot of activities that were not inconsistent with the use of the fund. So we have, and that's why even up to our voters, the way we better give them sugar and tea and unga. But in some places they are given raw tobacco, and he knows, Honorable Manson knows. So let's start from there, that as leaders, you help me in advocacy, because I agree with you, raw tobacco is more dangerous. But all tobacco, all types of tobacco, and tobacco accessories that come with, I think we need to advocate, and we need to make sure Kenyans are sensitized and they are told the effects. But Honorable Speaker, just to add, because tobacco is related to cancer, and I want to use the Solutium Fund mainly to upgrade the infrastructure of cancer facilities in our country. And I have started with making sure that we sign an agreement and pay for, from this fund, the servicing of all the cancer machines, whether it is linear machine, whether they're at our referrals, at our counties, so that at least they are serviced, they don't break down. We don't want to have a queue of our cancer patients, then they are told the machine has broken down. So we have agreed with our county government, particularly in the regional cancer centers, like Garissa, Mombasa, Nakuru, the one now at Jaramogi, Kenyatta National Hospital. We are putting some in Mwai Kibaki. All of them, we want to make sure that this Celestium Fund is used to pay for the service level agreement. Secondly, we also want to use this fund to build rehabilitation centers of drug addicts, government-owned, government-run, so that those of our young people who want to come back and reform, they have got very good facilities. They don't become victims of the private ones, which are run by private businessmen. So, and that's why I said we're doing one in Nakuru and one in Meru now. And I think finally we want to promote alternative livelihood. This will be a bit controversial in the regions where tobacco is grown. The growing of that tobacco, maybe they can grow rice, beans, instead of tobacco. Mainly in Migori, Busia, and Bungoma counties. So thank you, Mr. Speaker.
We now move to question number 025 by the Senator for Kisumu County, the Honorable Senator Tom Ojenda. Senator Hamida, you've been nominated to ask that question on behalf of the Senator for Kisumu.
Thank you, Mr. Speaker. Bwana Waziri, my question is, Senator Ojenda's question is 025. Could the Cabinet Secretary outline the measures in place to ensure that the Social Health Authority, SHA, processes and settles claims submitted by low-tier hospitals in rural areas and small private hospitals promptly, and with similar priority given to the settlement of claims from national and county referral hospitals? Thank you.
Honorable CS, you may proceed to respond.
Honorable Speaker, I just want to correct my earlier statement on this, on the Hansard. The 5 chronic counties, I want to correct it. Migori is not one of it. It's Kisii, Mandera, Wajir, Bungoma, and Homa Bay. That's where we have the biggest fraudsters. And they also constitute where we have closed more facilities. Honorable Speaker, the Social Health Authority has implemented a very robust measure to ensure that there is absolute equity in the processing and settlement of claims, regardless of the facility tier, regardless of the location of that facility, and regardless of the type of facility. Is it faith-based? Is it private? Is it public? Honorable Speaker, I want to say that claims are strictly processed on first in, first out principle. This means claims are paid as they are received from facilities, ensuring that low-tier rural facilities receive the same exact priority as our national referral hospital. So I really want to urge, and we have talked to, through our clinics, facility owners, and we have trained them that how claims are lodged is not how claims were lodged under the manual fraud-invested NHIF. Claims are lodged through a digital system, a digital superhighway. Two, our data confirms, and hospitals have confirmed, this equity function is in practice. And today, the settlement rate across all levels in the country is at 74%. Within the 90 days that this House has allowed us in law. The law says we pay all our claims within 90 days. But we are more proactive. Every 14th day of every month, we pay claims. But our claim level currently at 74%. In fact, Honorable Speaker, I was with the leadership of Tenwek Hospital, and they told me the claims rate in that hospital now is at 80%. Specifically, the settlement rate for level 2 facilities stands at, as a primary health care, stands at 73%. Level 3 facilities stands at 73%. And this is directly comparable to the 72% settlement rate for level 4 and 5. And level 6, our referral hospital, both public, private, and faith-based, is at 74%. To support cash flow for management for our small and rural facilities, the Social Health Authority has implemented a strict 90-day claims payment rule, and if possible, even do the 14th of every month, further, which we have been predictably been disbursing at the 14th of every month. And that's why I said from last Friday to this Friday, we are disbursed, and we have disbursed 13.5 billion shillings. If you look at the collection of NHIF, they used to collect between 3.5 to 3.7. That collection was for 5-6 months. So we know what we are doing and what we are saying. Honorable Speaker and members, at the PHC, we have paid all facilities up to January 2026. And the balance is because of exchequer release. Once we get that exchequer release, we will pay February and March and April. We have received also an additional 6 billion, with 2 billion for maternity services, and the balance 4 billion is for other PHC services. Why am I saying? When we had the summit with the President, the Council of Governors, and the President at the summit in December, we have agreed in principle that there are certain dispensaries and health facilities in far-flung areas that are far from level 4 and 5 hospitals, and still our mothers deliver. That was not factored in the architecture of the Social Health Authority. Now we can serve our mothers in terms of maternity in the rural part of Kenya, and they can deliver at level 2 and level 3. Finally, since the inception of the Primary Health Care Fund, We have paid facilities, and this is something I think my Honorable Speaker, senators must hear. This is the transformation of universal health care under President Ruto. Primary health care in our dispensary and health facilities. Close to 8.7 million Kenyans have accessed free health care in all our level 2 and 3, and a total of 19.8 billion has been paid in 18 months. They will walk to a facility, there is a charter, it's walk in, walk out, you see a doctor, you go to the lab, you go to diagnostics system, you go to the pharmacy, and you go home. In 18 months, 19.8 has been paid. In 18 months, 8.7 million Kenyans from all corners of our country have access. Today, the biggest source of revenue for our county governments is from the health sector. So, Honorable Speaker and members, the transformation undergoing in our country in the health sector under the leadership of President Ruto is real, is working, and Kenyans are appreciating across the country. Thank you.
Senator Hamida, any supplementary question?
No, Mr. Speaker, I don't have.
The Majority Leader.
Thank you, Mr. Speaker. I want to appreciate the Minister, a very hardworking Minister for Health, for taking time to come and respond to issues raised by citizens through their representatives, and also for highlighting some of the challenges we have in the health sector, including, you know, Speaker, I saw some idler on TV on Sunday claiming that we should revert back to the old NHIF system. The reports have been laid bare of the damage he left as chairperson of cabinet subcommittees those days. Mr. Minister, despite the good work you're doing, there's somewhere you have failed. The last time you were here, my good friend Waziri, you promised that you will file the report for the performance of the Social Health Authority in accordance with Section 42 of the SHA Act with Parliament after the lapse of the mandatory 3 months. That report is yet to be tabled in the House. You know, the beauty about that report, Waziri, is that it's the only way Parliament, and you have been leader for majority and you understand how Parliament works. That's the only way we can appreciate the good work that you're doing when you finally table a report before the House. So my question to the CS Speaker is, when is Parliament going to get that report in accordance to the law that this House passed, which the Minister is very well aware of? Lastly, just a comment. The Minister said when he was in Bungoma, out of 41 women that were in the maternity, 40 had registered with SHA, and there is one who had not registered because she did not have a mobile phone. I know the Minister to be a generous man. I hope he did not leave that lady without buying for her phone. Thank you, Mr. Speaker.
Senator Cherargei.
Thank you, Mr. Speaker. Sir, I want to appreciate the Cabinet Minister. He's one of the hardworking ministers of our time. And if all the hardworking ministers who are doing their job, all the ministers like he's doing, will have an easy ride in 2027. Mr. Speaker, my only concern, I was in Kericho County Referral Hospital, courtesy of your office, Mr. Speaker, and I found that SHA is working. Because in level 5, they are paying 3,920 per patient. The only problem, Waziri, is that there are no drugs. SHA is working, but when patients go to look for drugs, it is not within the hospital. So, Minister, when the reason they are saying SHA is not working is because they have to buy drugs outside the hospital. In your intergovernmental engagement with the Council of Governors, what are you doing to ensure that drugs are available in our hospitals? Because including your Garissa governor, even my governor, the Kericho governor, and many governors are not giving drugs. And that is why they are giving fodder to people who oppose SHA, that SHA is not working, but yet drugs are not in hospitals. So what are you doing with the governors? But you are doing a good job and you will go to heaven. I thank you, Mr. Speaker.
Senator Mundigi.
Okay, asante, Bwana Speaker. Pana Waziri, pongezi kwa ile kazi umekuwa ukifanya kwa hii wakati umepatiwa hii wizara. Tumeona ile unatembea mpaka kwa vijiji, na pia tumeona vile hata unapigana na watu wengine hata wabunge. Pongezi sana kwa sababu unafanya kazi hii ya rais wa Kenya na sisi pamoja. Pahali kuna shinda. Mambo ya kanza umeguzia, na kanza imekuwa disaster katika nchi yetu ya Kenya. Uko na mipango gani ya hii mambo ya kanza, kwa sababu watu wengi wajui ni pesa ngapi imetengwa kwa mtu mmoja, na pia miaka inayokuja kuna njia unaweza kupandirisha ndio ugonjwa wa kanza hiyo hakuna pesa mtu analipa, kwa sababu kwa watoto, kwa kina mama imekuwa ni shinda katika nchi yetu ya Kenya. Na kwa sababu najua unafanya kazi kama mambo ya bodaboda, vijana wengi walikuwa na shinda, ni sisi tu wachanga, lakini siku hizi unaona mtu akianguka na boda anaenda analipa saa, lakini anatipiwa. Kwa hivyo hata hii unaweza kuonyesha watu wa Kenya vile utaweza kusaidia. Asanti Bwana Waziri. Pongezi sana.
Senator Abbas.
Thank you, Honorable Speaker. Honorable Speaker, I want to thank the Minister for remaining steadfast and focused on the issue of ASHA, because there are so many busybodies that run around saying that ASHA is failure. Honorable Speaker, my question is that my county has been mentioned as one of among the four where the fraud is taking place. So I was asking myself, and I want to ask the Minister, what action has been instituted against those people who have made the fraudsters? Because we are not seeing people going to court. Thank you.
Senator Miraj, you've decided to go into hiding. Honorable CS, you may proceed to respond.
Honorable Speaker and Honorable Senators, let me start with the Honorable Leader. Honorable Leader, I do my work diligently, and on the 9th of April 2026, I made a submission to the Clerk of the Senate of the annual report of the operations of the Social Health Authority. And I have the letter, and because it was very voluminous, Annex 1 was NHIF annual report and statements. Annex 2 was on SHA annual reports and financial statements. Annex 3 was on PHC fund annual reports and financial statements. Annex 4 was on NHIF annual report and financial statements. Annex 5 was for the CCIF annual report and financial statements. And Annex 6 was on the Public Officers Medical Scheme Fund. And the Honorable Speaker, because it was voluminous, I presented a flash disk with a letter. I have the flash disk here. I have the letter here. Honorable Speaker, I can table this. So I do my work. Yeah, maybe, Honorable Speaker, maybe if you allow me, I have done the reports to the clerk. I have the letter, and I have the flash disk. I can still table this copy, the flash disk and the letter.
Clerk, kindly receive the documents and the deemed tabled.
Secondly, for leader, I want to confirm to the House that all the leaders in this country, both current and former, are members of SHA, including those who are saying SHA is not working. We cover the former president, his mother and his spouse. We cover the former vice president, Mudi Awori, himself and his spouse. We cover former vice president, Kalonzo Musyoka, and his spouse. And I'll continue and continue. So SHA is working. We have got a VIP. The whole of Parliament, you pay subscription to NHIF. And when you go to hospital for information, the first charge is SHA. Then we go to the medical scheme of Parliament. So SHA is working. Honorable Speaker, the other question from Honorable Charargei was the KEMSA order. I agree. We have a serious problem in terms of ordering. We have invested in terms of commodity and technology as government in KEMSA Today, KEMSA order fill rate is 92%. Every 10 products you ask KEMSA, they will provide you with 9. And by the end of this year, it will be 100% fill rate. But we have, the digital health superhighway has picked a very peculiar pattern for the House to know. And I'll just pick 3 counties. The county of Kakamega, and Governor Baraza is my witness. We found in the provincial hospital, referral hospital in Kamega, 52,000 patients have gone through the system. They have seen a doctor, they have gone to the lab, they have gone to the theater, but they have not been given drugs. We had the same problem with Nairobi. We see the patients moving, but when it reaches drugs, they don't get drugs. We have sent that with Bomet, and we have agreed, we have talked to the governors. And if you go to some counties, you'll see there are many pharmacies around the hospitals. We've seen the same in every place. And because we have recapitalized KEMSA and streamlined its governance architecture, we want our counties to draw KEMSA. Now our referral hospitals are drawing their products from KEMSA. So I think this is a question that we are working with the Council of Governors, and we want to make sure that, but what we have done in the system is that if you go through the system and you are a NHIF paid up or a SHA at the primary healthcare level, and you don't get medicine, SHA will not reimburse. It will reimburse everything else, but the bit of medicine, they will not reimburse. That will do 2 things. One, it will deny the facility money, so they will be forced to go and buy drugs and supply. My good senator from Tharaka Nithi, Embu, yes, I agree with you. Cancer is becoming a problem. We get 44,000 new cases every year. We lose between 28 to 29,000 of our citizens to cancer-related deaths. But we have established regional centers in Garissa, Nakuru, and Mombasa. We are increasing the infrastructure in Kenyatta Hospital, MTRH, Jaramogi. Now Kenyatta will have like 4 linear machines. Kenyatta serves close to 150 patients a day. So we have increased also the benefits for oncology in order to reduce the out-of-pocket. You remember the last time the president was addressing both houses, we increased it from, I think, 550,000 to 800. And we'll keep on reviewing it so that we deal with the non-communicable diseases, which are now very common. Cancer screening and reducing the risk factors like smoking, alcohol consumption, changing our sedentary lifestyle, among other things that we want to advise Kenya. Honorable Speaker, the last question was from Honorable Abbas. Honorable Abbas is very unfortunate. I also come from that region where the fraud is very high. I want to confirm to you that the people who are taken to court, majority are from Wajir and Mandera. The people who have did out-of-court settlement and paid SHA are also from that region, among other Kenyans. And the files which are being under investigation are from. So we are doing, and we are getting also very good facilities in Wajir and Mandera and Garissa and everywhere. And we want facilities that adhere to the law and treat our patients. What we are dealing with, we don't want crooks and cartels who want to eat and who are used to eating from NHIF. NHIF to continue the same business of fraud to SHA. SHA, unlike NHIF, is driven technologically. There is patterns. And Honorable Speaker, let me give 3 examples we have picked this week from the system, because I have an opportunity and the Kenyans are watching. We found a patient who has gone to hospital 5 times in one day the system picked. In the morning he was there, he said he had an ear problem. In the evening, at midday, he said he had a stomach problem. And these patients, so the collusion of fraud is between, some of them are patients, health facilities, and healthcare workers. 22 doctors have been denied access to the SHA and digital health system. Over 40 clinicians have been denied their rights because of fraud. And this will continue. We have found somebody who said his dependents are 375 children. I'm sure Senator Sifuna and myself, where we come from, where we are, because I saw Bungoma. Bungoma is leading in terms of children, you know. They told me every month in that hospital alone, 400 children are born, which is very, very good. Even from Earth, I don't think whether there is somebody who has a dependence of 372 children. And that person is from Kwale, and the DCI is investigating. We have found men who claim to have over 50 spouses as dependents. We have found women. We have, I'm sure even Kalwale doesn't have 50. We have found men. We have found men who claim to have over between 50 and 70 spouses as dependents. So what is going on in Kenya in terms of fraud? This is what used to happen in NHIF. But I want to tell them that the transformation that is taking place in our country with the support of this House, because the laws that we are using, the Social Authority, the NHIF, the regulations were all passed by this House, and of course the budget. Thank you very much.
We now move to question number 031 by Senator Catherine Muma. Senator for Nairobi City County, informed through a letter that you've been nominated to ask that question.
Indeed, Speaker, I have. Speaker, in this conversation, for as long as you hear people saying SHA is working, but there's always going to be a problem, and these questions by Senator Catherine Muma are pointers that there are issues still, and we must keep asking these questions despite all the backpatting that we've seen from some of my colleagues. This is the question by nominated Senator Catherine Muma to the Cabinet Secretary for Health. Number 31A. Honorable Speaker, what is the rationale for the 18-year age restriction in access to hearing aids under the Social Health Insurance Assistive Devices Benefit Package? B, when will the discriminatory age restriction be removed so as to allow adults with hearing impairments to access hearing aids under the SHA Assistive Devices Benefit Package? C, what is the ministry doing to address the high cost of hearing aids in Kenya? And could the Cabinet Secretary state whether there are plans to procure and distribute hearing aids through the Kenya Medical Supplies Authority or other government procurement channels to make them affordable? And lastly, Honorable Speaker, could the Cabinet Secretary outline the long-term strategies in place to enhance access to quality health care by persons with hearing impairments, and provide details on government's plans to train and recruit additional audiologists, establish hearing care centers in every county, and integrate ear and hearing care into primary health services to facilitate early screening, among other interventions? Thank you, Honorable Speaker.
Honorable CS, you may respond.
Honorable Speaker, the temporary 18-year age restriction on access to hearing aids is not intended to be exclusionary, but rather serve as an interim core containment measures driven by the current resource constraint within the scheme. I say this because the prioritization of individuals up to 18 years was strictly informed by the critical importance of hearing in speech, cognitive development, and educational attainment during formative years. So it also factors in the long-term socio-economic impact of early intervention, aiming to minimize the clinical outcomes within the limited physical space. On question B, Honorable Speaker and members, this restriction is not permanent. SHA working with the Ministry of Health, we are currently undertaking a very continuous actuarial assessment to evaluate the affordability alongside resource mobilization and benefits within the scheme. So we are working on a very progressive benefit expansion to include adults, and this will be planned and it will be implemented soon. But this is a function of the expansion of benefits for this age category will be guided by a body that is in law called Benefit Package and Tariff Advisory Panel, which must submit a report by September, which is mandated to review and advise on benefit design, the cost effectiveness, and how do we prioritize. So we have written, SHA ourselves, we have written to, is part of the things we have told the whole, a whole set of issues to be reviewed and for them to advise us on benefit design and the cost effectiveness. So this one is with that committee, and I'm sure they will make the right decision for the benefit of Kenyans who are in this category. What are we doing as a ministry to address the high cost of hearing aids? I agree that we recognize the high cost of hearing aids remains a very critical barrier, and it's very, not only in Kenya, in many of our African countries. It has become a barrier. It has become a barrier in terms of access. Hearing aids typically cost between 40,000 to 150,000. With most devices, again, are imported on a very small scale. They are sold through private outlets at prices which are unaffordable to the majority of our citizens. These challenges, Honorable Speaker, again is compounded by the limited audiology services outside the major urban centers. So the people who are suffering more are our Kenyans who are in the rural areas. Then again, as the Senator for Nairobi, on behalf of Senator Muma, has raised, we have a very serious shortage of trained specialists as a country. And we heavily, again, there's a heavy reliance on out-of-pocket payments. So the people at the bottom of the economic ladder suffer. And it also affects the whole concept of universal health coverage. So it brings the issue of inadequate access, particularly in rural counties. This again is further aggravated by the fragmentation taxation. There is an element of tax. While the VAT cap 47 accords preferential treatment to complete hearing, and I remember when I was the National Assembly, we removed that. But it was not done in a very structured way. Some aspect of it, of these hearing aids have been removed, are still holding some taxes as ordinary parts. So all these costs put together are passed to the user. So we need to address a whole ecosystem, a whole area where we feel ultimately we should reduce the cost. We are working with suppliers and importers and vendors, Honorable Speaker. Good example is, I said last time, we have reduced the cost of breast cancer, the drug that is used for breast cancer, from 120,000 to about 40,000. We are talking to other big pharma companies. Have an MOU with them, because the cost of care, cost of drugs in our country is very high. But we have standardized a specification for basic, mid-range, and advanced hearing aids in Kenya, assistive technology specification list, which will be incorporated into the Kenya Essential Medical List, which will allow us, this specification will be used to aggregate the national demand under the Social Health Insurance Fund, so that we see whether, leveraging on the economies of scale, we can use KEMSA to go and buy in bulk, pool procurement, and then talk to manufacturers and lower the prices. So it's something that we at the Ministry of Health are tackling, and I'm very happy the Honorable Senator has raised. But through the 80 Scale Initiative, which we are working with the Clinton Health Access Initiative, we are now procuring over 2,000 hearing aids for distribution to all our public health facilities and hospitals. And why is this? We are building on a very initial phase that has already equipped 27 facilities with the screening and diagnostic tools across multiple counties. So, Honorable Speaker, I have instructed KEMSA that hearing assertive technologies be now integrated into the National Logistic Management Information System, must be integrated into our Kenya medicine list that KEMSA and MOH has, and then we increase the screening and the diagnostic tools across multiple counties. Finally, the Ministry of Health, Honorable Speaker, will engage the National Treasury this year during the finance bill to propose amendments aligning the tax treatment of all hearing aids components, including essential parts, accessories, and consumables, are aligned and they are tax-free. This will help us ensure indispensable components of hearing aids are treated as integral medical device for persons with disability, rather than ordinary taxable spare parts, thereby reducing the out-of-pocket cost and advancing universal health coverage for persons. So we want to make sure that once that tax is removed, they can be financed and paid for under the Social Health Authority tariff. But the National Council for Persons with Disability has already initiated a framework agreement to strengthen the public procurement pathways of the whole country in terms of hearing assistive devices. Honorable Speaker. Honorable Speaker, what are our long-term strategies in place to enhance access to quality health care by persons with this condition, with hearing impairments? The ministry is implementing the National Ear and Hearing Care Strategic Plan 2023-2028. This is a very comprehensive framework, and it's designed to expand both ear and hearing services across all levels of care in our health ecosystem. And this plan helps to establish hearing clinics in all the sub-counties and integrate prevention, screening, and treatment into the primary health care services under UHC. So to strengthen the workforce, our community health promoters, our maternal and child health nurses are being trained both at our middle level colleges, at our universities. They will be trained in prevention, in early detection, and in referral. Concurrently, the University of Nairobi and KMTC and the Kenya Institute of Special Education are also scaling up how they can produce more audiologists and more speech, language, and therapists. Honorable Speaker, when I saw this question, I had to talk to the DG who is here. And I can confirm that as a country, we have serious shortage of specialists, even speech therapy. Even when we put the cochlear implant into our children at tender age, they recover very easy to hear. But the biggest problem is they recover and they take long on the speech therapy. So it's something we have seen, and I think we will talk to our training institutions and more Kenyans and to bring the curriculum and work through. Thank you, Honorable Speaker.
Senator Sifuna, do you have any supplementary question?
Indeed, Speaker, I do. Unfortunately for me, the ODM expert on PWDs is not in the House today, Senator Crystal Asige. But I do, if my memory serves right, we did pass as a House an amendment, Honorable Speaker, and I thought we touched on this question of taxation of assistive devices. It just doesn't make any sense why a government would impose VAT on essential components such as hearing aids. But I want to assure the minister that we'll be following up when that tax conversation comes up to see that this government actually does away with taxation on those essential hearing aids. But since the CS has pegged down the capping of receipt of these assistive devices to 18 years to the cost of the product, and if you look at the response, it's saying that it is a cost containment measure driven by current resource constraints. Does the CS or the ministry have empirical numbers? How many people above the age of 18 in the country, or what percentage of the population is actually in need of these things, so that we actually know that it is a heavy cost to government and you're not just telling us stories? Because you've told us here you are undertaking actuarial assessments, which I believe must be based on data and numbers. Do you have those numbers, Waziri, on how many people above the age of 18 in Kenya require these assistive devices? I thank you, Honorable Speaker.
Senator Duale.
Thank you, Mr. Speaker. A quick one. Waziri, I have a patient who has a heart problem and currently admitted at Tenwek Hospital, Bomet. Now, what I'm getting is that SHA is paying 537,000.
Now, Senator Duale, you know the
I am
subject of
building
the
my question,
the
Mr.
subject
Speaker.
of the primary question.
Mr.
You know
Speaker,
it.
I'm building my case. It's
Okay.
on SHA. I'm just inquiring.
Yeah, but the question at hand, the primary question, is
Mr.
actually on the devices.
Mr.
The
Speaker,
aids.
I raised my request earlier on when actually Senator Hamida was on the floor. And
So
even
it's not
before.
related to this question.
No, it's on SHA, Mr. Speaker.
I will allow you.
Thank you. So, Waziri, this patient is in the hospital and the bill is about 1.1. SHA is paying 530 something. The patient is supposed to pay the balance. Mostly on heart problems, people actually seek where they can be able to get quick response to their issues. I'm told there are criteria, or rather there are categories of payment for different hospitals and different diseases. So I really want to know more specifically on that particular patient or heart. I have about 4 patients from Isiolo who are having similar challenges, actually going around to raise funds to meet the cost of the operation. So do you have categories of hospitals and diseases that you pay different charges, especially those patients who are covered under SHA? I thank you, Mr. Speaker.
Senator Haji.
Thank you very much, Mr. Speaker, sir. Mr. Speaker, sir, before I go straight to the question, I just want to state that as a senator of Garissa, I am very happy and proud when I hear senators like Cherargei and Cheriot and Senator Sifuna praise the CS of Health, who happens to hail from Garissa. Senator Sifuna, you did say that he answered your question. No, you said he answered your question and you were very happy with his answer. So as a senator of Garissa, we're very happy and we're very proud of our son who hails from Garissa and he's got a very busy ministry and is doing a good job, and we want to wish him all the best. Mr. Speaker, sir, since regional cancer centers were established, they've been supported by the Ministry of Health through the supply of essential oncology drugs, which covered over 24 treatment regimens, including those for breast and prostate cancer. Over the past 1 year, we've seen a significant reduction in the supply of these oncology drugs. I would like to ask the CS to clarify whether if there has been any policy shift regarding the provision of cancer treatment drugs from the national government to the regional cancer centers, and how such changes affect facilities in marginalized regions such as Garissa County. Thank you, Mr. Speaker.
Senator Eddie Okech.
Thank you, Mr. Speaker. On the question by Senator Muma, Mr. Speaker, I didn't find it satisfactory. I've read the response here. Waziri, the question was, Mr. Speaker, when will the discriminatory age restriction be removed so as to allow adults with hearing impairments to access hearing aids under the SHE assistive device benefit package? Mr. Speaker, if you look at the response, I have no sense of idea of what timeline has been given by the CS. And with regards to that timeline, we need just to be very clear to be able to actually track that timeline, so that as Parliament we can actually be able to hold the ministry account to a timeline. So could the minister give us a timeline, not the narrative that is here? That
Honorable CS, you may respond.
Honorable Speaker, let me start with the last question. If Honorable Senator Eddie Okech read my statement, it's not a narrative. It's giving very clear direction. And I think Honorable Senator for Nairobi question is, because I have said we are looking at the whole issue. There's an element of taxation which we want to sort it out in this finance bill of this year. There is the element of we don't have specialists, but the element of the benefit package, which you have, I'm sure you are interested in when, is that we are looking at the current package, and that is under the Package and Tariff Advisory Committee, which we have submitted. It's an independent body that looks at many, including the one of cancer from 550 to 800. So, Senator, we will give you timeline. Once if tomorrow or the day after or next month the tariff package based at the University of Nairobi, if they give us, and they do public participation, they talk to the patient, they talk to stakeholders. Honorable Senator for Nairobi, I did not, the global percentage is about between 6 and 7%. And I suspect the same for Kenya. So 6% of the Kenyan population fall within this category, and I will give more detailed once I go back to the office and get the division. But I think it's about 6%. 6% comes to over 60 million, for example. If we say it's about 10 million Kenyans who are close to it, who are under this. Senator Dulo, yes. All our benefits for all is on the website of SHA, and all hospitals, both private, public, and faith-based, they use that, and it differs even within surgery. So, and I'm very happy to thank you for taking that patient to Tenwek. Tenwek is a place I have never been there. I mean, I used to hear, I went there. And in a day they do close to about, I think, 10 to 15 cardiovascular surgery, open heart surgery. Some of the best doctor surgeons are there. And I really want to ask even the House that it might be very far, and it might be in rural Kenya. But that facility, if you are in Bomet or that area, please visit. So I will, if you give me the name of that patient, I will look at it. But that patient is right, and I'm sure SHA does not pay everything. Maybe on that particular benefit, it's 500,000. But if you send me the name of the patient, I can ask the leadership of SHA if there's something that we can do. But Senator Sifuna, also 2.2% of Kenyans also have the same form of disability. Approximately 1 million persons, according to the last population census. Senator Abdul, but before I come to Senator Abdul, my sister, Senator for Isiolo, maybe we'll also look at the surgical package of that patient, because there are different surgical packages that the tariff is the same, and it's the same for all hospitals, both private, public, and faith-based. Kenyatta the same, will charge what Tenwek will charge, what Nairobi Hospital will charge, what Aga Khan will charge. My senator, thank you very much. At least I have not let you down. I am also proud of my senator. But yes, the Regional Cancer Center, at least in Garissa, with the help of the governor, and the same we are now doing with the governor for Nakuru, for the Regional Cancer Center, and the one in Mombasa. And Honorable Speaker, we are also building a cancer center in Meru for that region, and also in Nyeri, so that we have a lot of cancer. But the one in Garissa, number one, what we have done is we isolated it from the main hospital, and now it has its own SHA account. Before it was put together with the county referral hospital. So we've agreed with the governor and the leadership, now it's on its own account. So all the patients, and it serves about 10 counties, from Isiolo, Marsabit, Mandera, Wajir, Tana River, Lamu, Kitui. So it's a very busy place. I will even maybe, Senator, you need to help me, that we need to, there was some hostels, wards, which were started. We need to finish the wards, because the patients who come from far, they have a problem of accommodation, and it's a bit expensive for them. So what we agreed with these 3 regional centers, including Garissa, is that they buy the consumables, and then the Ministry of Health will take care of the servicing of the equipment. Because the biggest problem was the infrastructure. The machines were broken down very often as the patients are on the line. It happened in Kenyatta, now we have rectified. So Garissa Regional Cancer Center, Nakuru Regional Cancer Center, and Mombasa Regional Cancer Center, the Ministry of Health, using the tobacco fund, which is related to the upsurge of cancer as part of it, we are now paying for the service level agreement, so that the machines are serviced, and it's a very expensive exercise. It's costing us close to about 200 million for those 3 counties. So I think I will talk to the people in Garissa and ask them why they are not buying the consumables. I think they should buy it's on their part. Maybe you'll help me talk to the governor. And these 3 centers, Honorable Speaker, I think just to give as I said, 44,000 Kenyans are infected, cancer is affecting them in a year. So we have made a deliberate move that we build another 4 cancer centers, one in Kisii, one in Nyeri, one in Meru, and one in Kisumu. And I really want to seek the support of the House to help me sensitize screening for cancer. We need to talk to our people. Early detection, early screening is very important. Most of them are detected when they are at a very advanced level. And many cancers can be treated if they are detected at a very early stage, Honorable Speaker. So Garissa, we are working, and I think I'll also follow up what the Senator has raised once I leave here, just like the way I'll do for Mombasa and KNH and MTRH and all the other cancer centers, both public, private, and faith-based.
Honorable Senators, looking at the time, we are 50 minutes behind the schedule because there is time allocation for every question. I know we have one question left for the CS to respond to by Senator Minda Kibwana. So I have several requests here which I suggest, because they are actually on SHA, and we left that question. After the CS finishes the question by Senator Minda Kibwana, I'll give the senators Modama, my good friend Senator Kongo Mugeni, Senator Miraji, to ask those questions. A few minutes after he answers the question, responds to the question by Senator Aminda Kibwana. So Senator Aminda Kibwana asks question number 048.
Thank you, Mr. Speaker. Mr. Speaker, first I would also want to commend Bwana Waziri for tabling that report, for the job well done. It shows dedication, hard work, and he's actually equal to the task. And I'm very sure very soon we'll be calling him Dr. Duale with the expertise. My questions on 048, Mr. Speaker, is on Bwana Waziri, could you state the measures in place to operationalize the Kenya climate change and health strategy across national referral facilities and county health systems? Question B, what steps has the ministry taken to ensure that hospitals, clinics, laboratories, medicine supply chains, and emergency public health services remain functional during flooding, heat events, disease outbreaks, and other climate-related shocks? Question C, could the Cabinet Secretary state whether the ministry has conducted a national assessment of the vulnerable of health facilities and public health systems to flooding, extreme heat, vector-borne diseases, water contamination, and power disruption, and if so, what were the findings? The last one, what budgetary policy and infrastructure measures in the ministry adopting to strengthen climate health preparedness in line with practices used in countries that have integrated climate resilience into health planning, such as Bangladesh and the Netherlands? I thank you, Mr. Speaker.
OCS, proceed.
Honorable Speaker, the question by Senator Hamida is very, very important, not only to the Ministry of Health, but to the government and the people of Kenya. And that I want to confirm that we are operationalizing the Kenya Climate Change and Health Strategy 2024-2029 through very key measures and deliberate efforts. The first one is we are strengthening our institutions. A dedicated climate change and health unit has been established to coordinate implementation across the national referral facilities and county health system. And this is to ensure that we have a coherence policy and integration. Two, on vulnerability assessment, the Kenya Climate Change and Health Vulnerability and Adaptation Assessment has been initiated. Phase 2 has been completed by 31st of March 2026 with all the county level vulnerability profiles. All the ASAL and coast regions have been identified as high-risk areas. Phase 2 will form a costed health national adaptation plan. And the last one is climate resilient health guidelines. We have partnered support, and the ministry has developed what we call green health guidelines. We have also done the resilient health facility guidelines, which are available. What does these guidelines do? These guidelines provide a framework for climate resilient infrastructure, on sustainable waste management, and how do we deliver a very resilient health service across our country. On coordination platform, the Kenya Green Health Platform is being established within the next 3 months, and is supposed to coordinate implementation, supposed to track progress, and is supposed to strengthen accountability across national and county levels. On air quality and climate health intervention, the key actions that we did include the development of a household air pollution strategy, the training manual for our community health promoters, the 107,000, and this will help the community health promoters to strengthen the community level awareness and intervention. We are also establishing the Kenya Air Pollution Center of Excellence at Kemri soon, And as Kenya is a member and co-chair of the WHO-led Friends of Clean Air for Health initiative, this positions our country as a global leader in advancing clean air as a public health imperative. Honorable Speaker and members, our ministry is also strengthening the implementation of the Kenya Climate Change and Health Strategy through coordination with other institutions, making sure that we have evidence-based planning, making sure that we have resilient infrastructure standards that can withstand these shocks, and we have targeted air quality interventions. All these measures, I have said, will help our country prepare and the resilience of both at the national and the county level health system against any climate-related health risk. On what steps the ministry has taken to ensure hospitals, clinics, and laboratories and medical supply chains and emergency health public services remain functional. The Ministry of Health has instituted the following measures to ensure continuity of health services during the climate-related shocks. First is how we build resilient infrastructure. Implementation of resilient health facility guidelines to strengthen facility safety, particularly in high-risk area. So we have mapped out all our facilities across the country, particularly in the high-risk areas, to make sure that they have a very resilient infrastructure. Then, of course, we have, which is our core mandate, emergency preparedness. We have both strengthened the national and the county response system, making sure that we preposition enough supplies, we create a very rapid response teams, and we do emergency operation centers, working with colleagues in other critical departments. On supply chain continuity, that's why we said KEMSA now is fully recapitalized, so maintenance of buffer stocks, diversified sourcing, and improved logistics to ensure we are even introducing drones in terms of delivering items like blood during bad weather in some parts of our country. We are doing also surveillance and early warning, enhanced disease surveillance systems, detection and response to climate-sensitive outbreaks, the Rift Valley fever, and many, many others. Laboratory capacity, yes, working with the partners, including the US and other WHO, we have strengthened our laboratory networks and our referral system. Today, I want to confirm to the country that the samples we used to send to the US CDC and South Africa is no longer. We do a lot of our testing and samples both at Kenyatta and at the Cambridge labs. Workforce capacity, we are training a lot of healthcare workers and community health promoters on how they can respond to emergencies and risk communications. Honorable Speaker, on the question of could the Cabinet Secretary state whether the ministry has conducted national assessment? Yes, we have undertaken a national assessment of the vulnerability of health facilities and public health systems through what we call the Kenya Climate Change and Health Vulnerability and Adaptation Assessment, and this is in line with the Kenya Climate Change and Health Strategy 2024-2029. Of course, I have said the phase 1 is completed. We completed by 31st of March 2026, and that phase 1 provides a very comprehensive county level analysis of climate-related health risk and system. And what did we find out? We had very interesting findings. Geographical vulnerability. We found out that the arid and semi-arid areas and the coastal region were identified as the most vulnerable, with heightened exposure to drought, flooding, and extreme heat. We have also found out from this study that health facility infrastructure risk, a significant proportion of health facilities in the high-risk areas were found to be susceptible to flooding, inadequate drainage, heat stress, lack of power supply, And all this is affecting the continuity and provision of healthcare. We have also found out the disease burden patterns. In this assessment, we have confirmed that there's increased risk of climate-sensitive diseases. These include vector-borne diseases, malaria, waterborne diseases, which are linked to flooding and contamination and heat-related. So we also found the water and the sanitation and hygiene challenges, gaps were identified. We also identified gaps in the supply chain and service disruption. We also found out that laboratory and surveillance capacity gaps. Honorable Speaker and members, the ongoing phase 2 of this now will give us an opportunity and provide a more detailed and comprehensive national analysis. And its findings will form the development of a more costed. We want to put numbers to what we have seen. For the people at the Treasury and our partners to see. And this outlining very targeted intervention so that we streamline the resilience of health facilities and the systems. On the last question, what budgetary policy and infrastructure measures is the ministry putting to strengthen this climate health preparedness? Let me speak for the Ministry of Health because it is a multi-sector. Our ministry is, the Ministry of Health is strengthening the climate health preparedness through a very deliberate targeted budget, policy and infrastructure measures. And these are informed by the international best practice, including lessons that we have learned from Bangladesh and Netherlands. On budget, I think there is an integration of climate health priorities into our medium-term expenditure framework and annual budgets with the allocations. And I have just sent a letter to the Minister for Finance yesterday asking for budget on this issue. I hope in his wisdom under the tight physical space, he will consider and Parliament will consider when they are dealing with the annual estimates that will be tabled maybe next week. On policy and regulatory measures, operationalization of the Kenya Climate Change and Health Strategy 2024-2029 are all aligned with our national climate framework, and they are supported by what I earlier said, the green health and resilient health facilities. On infrastructure and system strengthening, we are retrofitting and upgrading health facilities for resilience to flood and advising our county governments and other private sector players, faith-based, they must build facilities that are resilient to floods, to heat, and power disruption. We are telling them and we are making sure that we promote sustainable energy solutions, and we also strengthen WASH systems and provide digital surveillance platforms. Finally, on capacity building, I think the healthcare workers are being trained, expansion on climate health research and establishment. These are areas I think they're very important, and I'm very happy, Honorable Speaker, that Senator Hamida has raised it. It's a very important area that has been neglected and was affecting us during floods, during drought, during heat waves. You see hospitals being submerged, outbreak of diseases which are related to the climate shocks. And finally, our multi-sectoral collaboration, we want to enhance the coordination with the government sectors and partners to support the integrated climate health response. Thank you, Mr. Speaker.
Mida Kibwana, do you have any supplementary question?
Bwana Speaker, I just want to add from the response from Waziri Asante for your response. I was just wondering if there are any, so far, are you assisting counties to mainstream this strategy so that at least they can have their own strategies and assessing and concluding this as you have tabled? And also, are you leveraging on also any kind of support, external partnerships? I'm sure there are countries that would want to partner on such, mainstreaming. So at least for the counties also to implement, their own, and then also just have partnerships whom you can leverage on. Thank you.
Honorable Waziri.
Yes, Honorable Speaker, thank you, and Honorable Senators. If you look at page 22 on phase 1, which we have just completed, 31st March 2026, we are completely aligned with the county level vulnerability profiles. That's how we picked ASAL, coast. So based on that report, and which we have shared with the counties, and everything we do, health is devolved. So as environment, most of it is devolved. So we're working with them, but I'm sure phase 2 is where now we want to inform a more costed national national adaptation plan, so that the counties can plan in terms of how much resources they will inject. And then finally, I agree with you, there are many partners, many organizations who are ready to partner with us. And what we have done now in the Ministry of Health is that we have introduced a system where it is one budget, one plan, one budget, and one M&E. So donors don't just come and they don't go to a county and they start something which already. So we sit with the donors, with the counties, and we say, this area has been funded by government, this area has been funded by this donor, we have a gap here, can you please help? So we will talk to our partners, both at the UN level and at the other international level. Many of them are ready to support us.
I have several requests here. Now, there are the same members I mentioned. I will give an opportunity at the tail end of this discussion. So, Senator Mudama.
Thank you, Mr. Speaker, for this opportunity. And I just want to, first of all, thank the CS for coming, because many of the times we call CSs and they don't appear. So thank you, Bwana CS, for coming. I have a question about a patient who was admitted at KU Referral Hospital, and he died a month ago. SHA paid 1,200, well, the bill was 1.202, and SHA paid 400. The balance of the bill was 800. Bwana CS, this man has only 3 daughters, and they are not working. They fundraised on the 13th of this month, and they raised 150. I was wondering, Bwana CS, at your capacity, what can you do, and is it legal for a dead person to be retained in a hospital because of non-payments, or they can come into agreements? The children of the deceased has already gone to the chief. The chief has written letters to the hospital. So, Bwana CS, I was wondering how you can assist for this body to be buried. Thank you, Mr. Speaker.
Before you get a response from the CS, I really wanted to know which other member has a supplementary question on the primary question first. You know, this is a technical area on climate change and health strategy. It's a technical area. The CS is lucky that he served in the Ministry of Environment, and that is why he's able now to understand what Senator Minda wants to know. So, Senator Nyutu, Joe Nyutu.
Thank you, Honorable Speaker. My question to the CS is based on Part B of the question that Senator Hamida Kibwana asked on the steps that the ministry is taking to ensure that clinics, laboratories, and medical supply chains are served or are available to these institutions, public health, medical facilities during when we have disease outbreaks from climate change, Mr. Speaker. But then, Mr. Speaker, we also have a big referral hospital in this city by the name Kenyatta National Hospital. And there have been reports, Mr. Speaker, that sometimes supplies, even laboratory supplies, medicine supplies, are not available, which has been resulting from the fact that the government is collecting all the payments there through the e-citizen platform. So, Mr. Speaker, my question to the CS is, what informed this decision to have monies payable to Kenyatta National Hospital collected through e-citizen, which then means that the hospital cannot access those funds directly? And Mr. Speaker, you know, hospitals are doing very well in the counties when they collect these monies for themselves and use it for what we are calling facility improvement fund. So exactly what informed this, and what guarantee do we have, Honorable CS, that Kenyatta National Hospital will continue having medical supplies and laboratory supplies, in spite of the fact that the hospital does not collect this money directly, because it is collected through an e-citizen platform? Mr. Speaker, that is my question. Thank you very much.
Senator Joe Newt, you know you are a bit crafty. You are touching on climate change and then diving again to Kenyatta National Hospital. Yeah? So that is why I'm asking any member, if there is no other member on climate change issues, then let's get another question from Senator Okongo Mugen.
Yes, Mr. Speaker, mine is a supplementary question to the answer that was given by the CS. And I first want to thank his ministry and the CEO of SHA, because they made an intervention for a patient. I think that was last week, who was being asked to pay an advance payment of 45,000 shillings in a private hospital in Kisii before accessing dialysis. And I think that was an attempt by the hospital to extort money from a patient who is fully covered by SHA. Now, Mr. Speaker, sir, the CS has emphasized that it is important for Kenyans to go through cancer screening. And I just wanted to get the thoughts of the minister, how he can assist the very vulnerable Kenyans who are supposed to get these services from our county referral hospitals, yet those hospitals don't have the facilities to do cancer screening. I can give an example of my own county of Nyamira. We don't have MRI machines. We don't have facilities that can allow patients to go through intestinal cancer screening. I think what they call endoscopy. If you go to a private hospital like Nairobi, I think they charge about 37,500 just for the facilities alone. The doctor will charge another 55,000 shillings. Yet at the counties, Mr. Speaker, I don't know about your county of Meru, but most of our counties don't have these facilities. In fact, in Nyamira, we don't have an oncologist. We don't have an MRI. We don't have a radiologist. So even if we urge Kenyans to go for screening, the only fallback is to go to our private hospitals. In that region, there is only one private hospital, Oasis, that can allow patients to go through screening. So my question is, can SHA, the SHA card, especially Kenyans who pay 500 shillings, can they enjoy this service of early cancer screening in our private hospitals using the SHA cover? Because the facilities are not in our public hospitals. And I'm willing to visit with you my county hospital of Nyamira, or you can make reference to the auditor's report, financial year 2024-25. He has highlighted that all these specialists have not been employed by our county government of Nyamira, plus all the 3 other level 4 hospitals. That is the situation. So I want to know whether that service can be available to the people I represent to get the cancer screening. Thank you, Mr. Speaker.
Okay, last but not the least, Senator Miraj Abdulilai.
Asante Mheshimiwa Spika. Swali langu kwa waziri ilikuwa ni kumuuliza kuhusiana na masuala ya malipo ya SHA katika hospitali zetu kuu za referral, hususan ile yetu ya Pwani. Lakini katika changizo zake nimemsikia amesema kwamba tayari wametayarisha malipo hayo. Kwa hivyo yangu ni pongezi kumwambia ya kwamba sisi kama Wapwani tunaitegemea sana hospitali ile, na tumefurahia pia kusikia ya kwamba kuna facility ya kansa inaendelea kujengwa pale ndani. Asante Bwana Spika.
Kanuni ninazotumia hapa ziruhusu wewe utoe shukrani saa kama hizi, ni maswali tu ya ziada. Lakini ni vyema, wengi wameshukuru waziri na sina bundi na mimi pia kusema anafanya kazi jema. So there are three just supplementary questions from Senator Kongo Mweni and Senator Kibwana and Senator Njonyu. If you do that in 1-2 minutes, we'll be concluding with you, Waziri. Thank you.
Honorable Speaker, I will be very fast. Honorable Senator for Machakos, Senator Mudama, I really understand your case. SHA has paid 400,000. That is all they could pay as per the benefits of the patient. Now the patient has 800,000. From my experience, even now as a leader and when I was in Parliament, there are some bit you have to pay yourself. We have to do a rambe for that 800. Me, you, and many others. So, no, you have said only the family has 800. So what you do, send me the list. Please see how much we can raise. And then I will see how much the hospital can waive. And I will deal with that matter. It's very urgent. We don't want to keep bodies. It's against, it's immoral, it's unconstitutional. And I will do, but we should also protect our hospital. But that one, I'll deal with it. And there's a certain threshold that we can ask KU to RH to waive. Two, my good friend Senator Nyuchu, I want you to go to Kenyatta Hospital today. Just yesterday alone, Kenyatta Hospital was paid 531 million by SHA. It was number one. For many reasons. One, it has a high number of patients. And two, there is a new good leadership. We have removed all the corrupt ones. And the board led by Abbas Gulet, former Kenya Red Cross chair, and the Siampe who was before in Kenyatta, and now they are doing extremely work. 11 wards are being refurbished. Even their money, the little that goes through e-citizen platform, they get it. So what you read in social media is fabrication. In fact, I'll be going to launch another section of Kenyatta. I'll look for you. So Kenyatta is not the Kenyatta of the yesterday. And I really want to tell the country, both the private wing, and in fact the private premier wing of Kenyatta now is being used by our leaders. So Kenyatta is doing well. It has enough money, and e-citizen has transformed our country. Senator, e-citizen has transformed our country. You might not like the president who introduced it or the government introduced it, but while you are sitting here, you can use e-citizen platform to sort out many personal community issues and payment. And you do payment here, Kenya Power, whatever, anything, KRA. So I think it has challenges. The way even, I'm not saying SHA is 100%, we have some operational challenges. The way M-Pesa sometimes is in a kwama, but I can tell you Kenyatta, and I'm ready to take you there. The supplies are there. They buy from KEMSA. Where they don't find KEMSA, they buy from the private sector. In fact, by next week, we are putting the 4th linear machine for our cancer patients. They serve 150. We want them to serve 300, 400. Kenyatta University is a premier. It serves Murang'a, Kiambu, Machakos, the whole of that region. But Kenyatta Hospital is doing very well. I think there was a question from Senator Omogeni. Senator, I want you to listen to me. I didn't want to say this, but I have to say, healthcare in Nyamira has collapsed. And it has collapsed because of your governor. I want to be very honest with you. There are about 3 counties where healthcare is collapsed. Let me give you a very good example. All the things you have said, all the equipment you have said, are provided for under the National Equipment Support Program. I was in Bungoma, his counterpart. There is a radiology, there is a mammograph, there is dialysis machine, there is even a CT scan we have launched, all under this program. And he is not putting a coin. The national government is not putting a coin. It is fee for service. Every patient who uses it is paid for by SHA. Your governor and Nyamira, he has signed for the next program, but he's unable to make a request. He's unable to make a request, and I cannot force him. So if he make a request today, by next week, me and you will go and launch CT scan. We'll go and launch all these equipment. But I can tell, and it's good, I think I need to be very honest to Kenya and to the residents of Nyamira, that I think it is morally wrong, it is religiously wrong for you to be a leader and to be a governor of Nyamira, and you allow the most critical sector to collapse because of leadership. I didn't want to say this, but I have to say it. Even the primary health care, which is free, level 2, level 3, the dispensaries and the health centers, it is free. Government is paying for. And if you look at the money, if he does well in health and put the equipment, even the revenue of Nyamira County from the health sector will be the highest. I will give you a good example. Senator Miraj asked me, Coast General Hospital, yesterday we paid them over 235 million. I have the chief finance officer of Shahia. I think it's about, it was number like 6. Nakuru General Referral Hospital. There are counties that have received close to 8 billion since SHA started 18 months ago. It depends on leaders. But because today the senator, a good friend of mine and a very progressive senator, even look at that 45K of dialysis. It's not even the price. Dialysis, the 2 sessions are fully covered by SHA. No Kenyan should be charged as long as he is a member of NHIF. Every Kenyan who goes for dialysis, 2 sessions, they are fully covered by SHA. There are few Kenyans who go for 3rd session. We are trying to look at the benefit package and maybe get it from another package. And maybe by the end of the year, we will make sure that all the dialysis package are covered. I have just said Nyamira is next to Kisii and Bungoma and Mandera. The private hospitals there are part of the fraud that is going in the country. Thank you, Mr. Speaker.
Okay. Thank you, CS, here for your time to appear before the Senate. So, as you have heard clearly from the senators, they are happy with your work. Continue doing this and good work with your team. So, I want to release you to go and serve other Kenyans. So, Waziri, I have released you. Now, we are happy that you have been able to handle the questions nicely, because you have taken a lot of them, because you understand the subject matter of whatever is happening there. So, thank you very much indeed, and all the best. So we have the next CS, the CS for Interior, National Security. So I request the Sergeant at Arms to usher in the CS.